Thank you. I'm going to set a timer here because this was originally an hour talk when I made it. So yeah, thanks a lot. I'm from Pittsburgh. It's always great to follow Dr. Seyfried, especially when earlier in the week he sends you an email talking trash about his Patriots beating the Steelers. Nonetheless, so at Pittsburgh, I'm an assistant professor in the Department of Radiation Oncology. I'm also board certified in integrative medicine, so I see consultations for patients who want to prevent cancer, so we discuss dietary and lifestyle interventions. Last year I spoke on some of our protocols and data on enhancing cancer treatment through a ketogenic diet, so similar to what Dr. Seyfried spoke about. This year I'm going to back it up a notch. We're going to talk about cancer prevention. My only disclosure is I started the Cancer Prevention Project. I make absolutely no money from that. And my book, Misguided Medicine, a lot of the controversies in this talk are in that book, so I do profit from that. Last year I discussed this study, and this is one of my personal studies that kind of got the ball rolling for me when we looked at dietary recommendations that were given to cancer patients, both during treatment and after. What were we telling patients? This was at the NCCN Cancer Centers, and as you can see, recommendations are all over the map. So most places, there's 22 total, and most places don't even give recommendations, only 4 did. An additional 4 outsource them to other websites where they give recommendations like this, where patients should eat almost a 80% carbohydrate diet, which is extremely concerning based on all the data we've heard basically in the last 2 days. Counter to that, you go over to the West Coast and they tell people to eat a higher fat diet, just more calories. They just don't want them to lose weight. Weight loss is correlated with worse outcomes for cancer patients. So the next question is, what do we tell people before they're diagnosed with cancer? And we're going to get into that later on in the talk. Any study in this talk that I talked about last year, I'm going to go through very quickly. So if you have any questions regarding them, just the video's on YouTube, so you can refer to that. But this was one of the first studies that we did in Philadelphia, where we took mice. We implanted a mammary tumor into their fat pad. We let it grow till it was palpable. And at that point, we randomized them to 4 different arms. The mice were given, 3 different arms. The mice were put on an ad libitum diet, so they could eat as much as they wanted. They were fasted every other day, and then they were calorie restricted. So this was 30% restriction of a very high carbohydrate diet. And we gave them a single shot of 8 gray of radiation. This is not a curative dose, but enough of a dose to slow cancer growth, and indeed it did. This is the tumor growth. Up is the volume, right is the days after, so quicker up is quicker growth. Mice that just eat as much as they want with a breast cancer, the tumor grows quite quickly. Radiation blunts that growth. Based on this dose, calorie restriction actually slows the growth of these tumors even more, so simply changing their diet and nothing else slows the growth of these tumors. And then doing the 2 together, they work synergistically, and that's what a lot of my talk was last year, about how we need to add these metabolic therapies in with the standard of care and then start pulling things away. We also did alternate daily fasting. Didn't work quite as well, though the study was not meant to compare the 2. But again, simply fasting mice every other day and giving them radiation causes their breast cancers to grow slower. The nice thing about this is people's weight, it drops initially, but they catch up. So this is something we could theoretically do in humans. We could make them fast every other day, depending on what their treatment is. And then last year, we left it with Dr. Sheck's study. I'm a radiation oncologist, so this is certainly near and dear to my heart. She showed that first off, mice with glioma, that if you simply put them on a ketogenic diet, they lived longer. The red line there is keto-cal. To the right, that means those mice were surviving longer than the other mice. And if you put them on a ketogenic diet and give them radiation, 9 of those 11 mice no longer had any tumor specimens left in the brain. So that's quite an impressive study. So Dr. Klement he gave a talk yesterday. He was kind of the force behind this, but we went through all of the mouse studies. I would like to say we went through the human studies, but of course there aren't many. There are none, actually. These were all the randomized studies in mice. We had a strict criteria. They had to compare a regular diet and a ketogenic diet, and we looked at the results it had in slowing tumor growth. So I'm just going to show you one of the many pictures, but anything to the left of this is good. That's a hazard ratio, so less than 1 means they had a lower risk of dying. It meant the ketogenic diet worked better. And as you could see in the vast majority of studies, indeed it did. The hazard ratio is right there. It's about 5. This is on PLOS One. It's a free study. Please check it out. The stats, Rayner did the stats, and they are the most mind-blowing. Like they're not understandable by anyone without an IQ of about 500. But nonetheless, he set up these models to basically figure out if and when the diet worked best. And indeed, the diet, these mice lived longer. It slowed tumor growth. But as Dr. Seyfried discussed, the diet in itself is not enough to treat cancer. But the question we started to look at is it enough to prevent cancer? And this was basically our last sentence in the study. If the timing of the ketogenic diet is of major importance, this would imply a role of fasting and ketogenic diets as a prevention strategy in humans, but only as a supportive role during cancer treatment, which is consistent with the current available human data. Further studies in humans to test these hypotheses are warranted. So when I presented this data to several of my colleagues, they were upset. We thought the ketogenic diet in itself could possibly cure cancer. We were hopeful. It still certainly has a role, but this was encouraging to me. If we can actually somehow use it to prevent cancer, that may even be much more of a powerful message, albeit not a marketable message or a profitable message, but in terms of health, it would be obviously amazing. And so if we back up from this data to some of the studies that we discussed last year, it's consistent. So if you look through a lot of the papers I wrote to support why we're looking at a ketogenic diet, why we looked at calorie restriction, if we looked back through the last 100 years, indeed there's a lot of studies, but if you look at the vast majority, they're about stopping tumor incidence, not necessarily treating cancer. And again, I don't think that's a bad thing. This is the first study that I know of. This is the Mareshi study in 1909 that we discussed before when he implanted sarcomas in mice after they were started on calorie restriction. There's 4 different groups. I'll be brief here. The mice that ate an ad libitum diet, the mice that ate as much as they wanted, those tumors grew fast and they grew large. The mice that were calorie restricted, those tumors grew much more slowly. Again, this prevented tumor growth. In 1913, only 4 years later, this is I still think to this day, the biggest mouse study. There's between 200 and 300 total mice that were in this study. Same thing, they put them on different diets. They gave them different carcinogens. They had different tumor cell lines, et cetera, and they looked to see which cancers grew. And what they found was something similar. There seems to be no reasonable ground for doubt in view of these experiments that a lack of carbohydrate in the diet produces such an influence upon the rats as to make them more resistant to tumor growth. When the diet includes carbohydrate, the tumors grow luxuriantly. When the diet does not include carbohydrate, the animals show a marked resistance. This was contested with some other studies, but again, in continuation of what we discussed last year, there's something pointing towards carbohydrates, not just in treating cancer, but perhaps more powerfully in preventing cancer. And Dr. Tannenbaum did probably some of the most studies, at least before 1950, and all of his studies looked at the incidence of tumors. So a lot of us use these studies to promote dietary changes to treat cancer, but again, he's looking at the incidence of different types of tumors, different types of mice that can generally get higher rates of cancer, and then also giving carcinogens to mice after you put them on different diets to see which ones grow tumors and which ones do not. The dark line here is the amount of tumors that mice get when they're fed an ad libitum diet. The pencil shaving line here is the amount of tumors the mice get when they're, quote, calorie restricted. So again, calorie restriction, varying caloric intake decreases tumor incidence, and then in some of his studies it did decrease tumor growth. Again, when you look closer, the biggest differences that he saw were when you restricted carbohydrates. And even in some of his studies, it's unclear if he's even restricting calories or simply replacing carbohydrates for fat, and it's questionable if calories are even going up or if they're even, but again, there's something about carbohydrates that decreases the incidence of cancer in mice. So no talk about cancer prevention would be complete without discussing the hallmarks of cancer. This is a paper that has been cited, I've heard it's up to 30,000 times, I don't know if that's true or not, but this was by Hanahan and Weinberg, and these are what they said were the 6 hallmarks of cancer: resisting cell death, inducing angiogenesis, enabling replicative immortality, activating invasion and metastasis, evading growth suppressors, and sustaining proliferative signaling. This smells awful fishy of the genetic view of cancer. So that was in 2000. This was another picture from it. It shows all these different pathways. So this to me says this is why a lot of the treatments we're doing aren't working. So you think blocking EGFR is going to affect all those different pathways? No. We need something more global, especially when it comes to prevention. Interestingly enough, they redid this paper in 2010. This is the Hallmarks of Cancer, the next generation. They added 4 more hallmarks on here. These start to look a lot more like what Dr. Seyfried was talking about. Deregulating cellular energetics, genome instability and mutation, tumor-promoting inflammation, avoiding immune destruction. When I read this paper, that to me really starts to point towards lifestyle behaviors. What can we do to globally affect all of those? Obviously, eat a healthy diet, exercise, deal with stress much better. So the next question from all these papers is what do we actually tell patients? So, we can sit up here and talk about studies all day long, but at the end of the day, what do we tell people? What do we tell patients so we don't end up with that first paper where recommendations are all over the map? I give this talk at grand rounds to multiple cancer centers. I used to get tomatoes thrown at me all the time. Those happen less often. A lot of the papers I'm going to discuss here are where I came, or how I came to what I tell my patients. So all these studies are implicating carbohydrates in regards to cancer. And obviously it's a little more, it's not as simple as that. And then at the same time, you have papers like this coming out. You have Dr. Anichkow in Russia putting cholesterol in rabbits. Rabbits eat a vegetarian diet. When he fed the cholesterol to these rabbits, their arteries clogged. This was in 1913, same year as that other study looking at carbohydrate consumption in mice. Thus, from that point was born the lipid hypothesis. Ansel Keys did his famous 7-country study, further implicating, he thought it was more fat, so not necessarily cholesterol in the diet, perhaps fat in the diet. We could talk about this for a day in itself, but because of all these issues, our dietary recommendations at that point obviously implicated fat. Interestingly enough, during that same time, there were other areas where Ansel Keys and his buddies weren't looking, but perhaps if they were, we'd have very different dietary recommendations. Is anyone familiar with Rosetta? It's a small town in Pennsylvania. So it was started by a group of Italians that lived in Rosetta in Italy, a group of Italians that drank a lot of wine, smoked a lot, ate a lot of prosciutto, ate a lot of fat, and by the way, they rarely ever died of heart attacks. So made no sense at all. Because of that, Dr. Wolf, some of these other physicians went into Rosetta, did a whole battery of tests on them from the 1960s into the 1990s, trying to explain why this was happening. They eventually wrote a book saying, it's called The Power of Clan. They thought that it was the fact that these groups grouped together, they were very happy, they were very like a tight-knit group. They thought that was the reason why they had no heart attacks. We still don't exactly know. Around the same time the Rosetta story came out, Land and Sperry published their paper looking at aorta fat content and showed that it was not related to cholesterol at all. And then, I need to update this slide, but if you look back through a ton of these prospective studies that gave us the lipid hypothesis and our dietary recommendations, yeah, sure, a couple showed that eating saturated fats increases your risk of heart disease, but a heck of a lot more show that increasing your consumption of polyunsaturated fats increases your risk of heart disease. And that's going to come back to play into cancer, and we'll touch on that at the very end of the talk. Another interesting thing to look at, Stout and his group published about Rosetta. This was in JAMA, and in all fairness, this picture was from the book that they wrote, not the actual study. On the left here, these are all 1960s when they had no risk of a low risk of heart disease. On the right here is in the 1980s when they assimilated back to basically American society. They started having heart attacks just like the rest of us. He actually put this in as an afterthought, and this stuck out to me more than anything. This is the amount of lard they were eating. That was when they were having a low risk of heart attacks. That was the amount of butter they were eating when they were having a low risk of heart attacks. 4 more eggs per week, and obviously healthy olive oil. This was their cholesterol, went up significantly when they reduced their fat consumption. Doesn't prove anything, but I think it's rather interesting. So looking at all these studies, when we start to make recommendations to patients, we have to look at epidemiologic studies. So our main business of life is to not to see what lies dimly at a distance, i.e. epidemiologic studies, but to do what lies clearly at hand. And I have a whole slew of slides on this that I took out because it would be way too long. But Gary Taubes and a lot of others have talked about one of the major epidemiologic studies that set the tone. This was Stanford and the group up at Harvard. They published this in the New England Journal of Medicine in 1985, 122,000 female nurses. They adjusted for everything under the sun, even parental MI, and found that those women who were using estrogen, hormone replacement therapy, had a 50% decreased risk of coronary artery disease and a 70% decreased risk in current users. As a result, many people, including many of my family members, got prescribed estrogens after menopause. When they actually ran a randomized study, so again, going from a distance and seeing what lies at hand, they found that postmenopausal hormonal therapy increased heart disease by 30%, increased breast cancer by 26%, increased stroke by 40%, increased blood clots in the lungs by 113%, did reduce hip fracture, so one benefit there, and overall total cardiovascular disease was increased by 22%. So this is what happens, and Taubes talks about this in Good Calories, Bad Calories. This is what happens when we make recommendations to people based on epidemiologic studies. So I always ask, are recommendations backed by population data, mechanistic support, animal data, and randomized human data? Because if not, you're left with lies, damn lies, and statistics. And further, kind of laughing at this all this is Dr. Schoenfeld, who's actually a radiation oncologist. He did this with Ionitis, who's been really critical as of recently, very bright guy. They went through the Boston Cookbook and found that basically every food in there causes or cures cancer based on what epidemiologic study you refer to. So it's a great paper, but I mean, it's a joke. It's all over the map. Wine is more good than bad, apparently, so I'm going to quote this every time patients ask me if I drink wine, because I do. To further illustrate that point, there's plenty of studies like this, and we actually have a paper coming out soon. This one by Burns-Whitmore in the Nutrition Journal. They gave humans in a randomized fashion 2 different eggs. One was the chickens were eating N3 fatty acids and walnuts, and the other one they were fed traditional eggs where they're in a crate. And what they showed when they took blood samples from these participants is based on the type of egg they had, their N3 amounts were significantly higher with the N3 fatty acid eggs. ALA was higher, DHA was higher as well. This is why epidemiologic studies are not helpful in that regard. If you ask people if they eat eggs, and an egg is not an egg, then what are we actually getting from this? So what tangible recommendations, and I'm going to speed up here, so I apologize. So what tangible recommendations can we give patients to help prevent cancer diagnosis and recurrence? Does anyone know where that is? So that's in Ravello. Okay, it's in southern Italy. I like to go there a lot. I like to write about the Italian diet. I said, give me what everyone eats. That's a buffalo mozzarella. It's made about 2 hours south. Higher amount of fat, higher amount of protein. This red wine has some of the highest amounts of tannins and free radical fighting components. Obviously, you got your prosciutto there, and like the Rosettans, they live forever. So should we avoid fat or do the opposite? This is the number one question asked of me by patients. That again is buffalo mozzarella and pastum. So to answer this question, we have to look at deregulating cellular energetics and tumor-promoting inflammation. So these are 2 things that cancer cells want. It's going to help them to grow. Inflammation is like the fertilizer of cancer cells. So we want to decrease that from happening. So what we want to do is, and this goes back again to the talk last year, we want to decrease insulin, we want to decrease IGF, and we want to decrease glucose. Why? Because it stimulates cell survival, cell growth, and inflammation. And these are all pro-cancer pathways. On the other side of things, this is AMP kinase. That's upregulated by carbohydrate restriction, fasting, exercise, metformin. And that's exactly what we saw in our study. So when we had mice on a high carbohydrate diet and we decreased it by 30%, those energetic pathways were downregulated. So IGF, insulin receptor pathway, PI3 kinase, mTOR, these were all downregulated through dietary treatment alone, and this did synergize with current treatments, but again, in terms of prevention, I think this is a little bit stronger. And it did downregulate the survival pathways of the cancer cells. And this is why we see studies like this. Men, the serum insulin of men, so the amount of insulin circulating around in their blood, is directly proportional to the risk of getting prostate cancer. So why is that? Because it promotes inflammation. It promotes cell growth. It promotes all these things that cancer cells love, that the new 4 hallmarks of cancer thrive on. So do we have evidence in humans of which diet we should eat to downregulate those mechanisms? We do. We have a lot. None in cancer patients, and I don't think that evidence is going to come out anytime soon in cancer patients, but we do have a randomized study in 21 non-cancer patients. 7 of each were put on a different diet after a run-in phase of a basically standard American diet, perhaps a little light on the carbohydrates. It was 40%. This is Kara Ebling and her group, and this was published in JAMA. When we put them on a low-fat diet, 60% carbs, 20% fat, this is like a traditional dietary recommendation dream right here, or a low GI diet, we upped the fat a little bit, or a very low carbohydrate diet right here. It was not necessarily ketogenic, it was quite high fat, 30%, 60% carbs were 10, and protein was 30%. So that's a high enough protein where it probably knocked a lot of these people out of ketosis. So what do we see? I stole these from Peter Attia, so thanks Peter. HDL and triglycerides were improved significantly. Dr. Volek has discussed this quite a bunch, and that's as we expect. In the low-fat diet, HDL did drop significantly. That's worrisome. That's a whole different topic. Most importantly for this, peripheral insulin sensitivity and hepatic insulin sensitivity increased significantly. So in people without cancer, we're downregulating pathways that we know can cause cancer. That is the best diet here. And a low GI diet's not too shabby either, and for some people that's probably better than a low-fat diet, maybe not as good as a low-carb diet. Jeff had this in his talk earlier today from the Cassandra Forsyth study. Glucose drops by 15%, and insulin drops by 50% when you put overweight people on a ketogenic diet. And that's even if you tell them they can eat as many calories as they want. So that's going to help regulate cellular energetics, and it's going to decrease tumor-promoting inflammation. And that is what I tell my patients because it's based on dozens of randomized studies. So my tangible recommendation number 1 is to eat less simple carbs and those that stimulate glucose, so sugar, pasta, bread, modern grains. I tell them not to overconsume protein. Lean meats and protein supplements can upregulate the mTOR pathway and IGF. And do I tell them to take metformin? I don't, but if they have diabetes and they're on a medication, I would prefer, if they're type 2 diabetic, I would prefer it's metformin. Not enough time to talk about that. So next is, do I tell them to eat less? And I understand why people have told people to eat less. Conceptually, it makes sense. Much like the serum insulin study in men with prostate cancer, this is a body fat study in women diagnosed with breast cancer. This is weight, this is gaining weight, this is losing weight. Going up is bad, that means you have a higher risk of cancer. Women that gain weight after menopause have a much higher risk of breast cancer, so we do not want them to gain weight. So do we tell them to eat less and exercise more? I don't have enough time to go through this, and a lot of people have discussed this today, but when our mitochondria get pumping and pumping and pumping, we have oxidative phosphorylation in the electron transport chain, a bunch of free radicals are made. And if we overload the mitochondria, with any type of food, and this is a contentious topic, but any type of food, several things happen. Free radicals leak out, there's proton leak, and there's mitochondrial fragmentation. So what happens is these free radicals basically start shutting off the cell. It's like a part of a ship. If there were a leak, it locks it away. Fatty acids can build up. GLUT4 gets shut down, so less glucose comes into the cell. Insulin gets shut down too, so less insulin comes into the cell, which means more insulin floating around. More of a diabetic state, and more glucose floating around. So we do want people to not eat too much. So then the next question is, do we tell them to eat less? And I don't. I tell them I want good stress versus bad stress, because that's what's going on here. We're stressing the mitochondria in a bad way. I tell them to fast. I tell them to exercise. I tell them to go into ketosis periodically. I tell them to do things like come up here and give a talk, because that's acute stress. Energy overload, these are the bad stresses, come from excess calories, diabetes, obesity. That decreases our mitochondrial function. As Dr. Seyfried just talked about, we don't want decreased mitochondrial function, we want increased mitochondrial function. And I don't tell people to exercise more and eat less because it doesn't work. This is one of Dr. Finney's studies from, 1988. When he put people on a 700-calorie study, their resting oxygen consumption dropped significantly. It's 10% down there. When he exercised them, we're about 72%. So this is why people feel terrible when they eat less and exercise more, and when you tell patients to do it, they come back a week later and are no longer following your recommendations. So I tell people to do what the research tells us. So which diet allows people to eat less? A low carbohydrate diet, regardless of calorie restriction or not, has never been shown, to my knowledge, never been shown to be inferior to a low-fat, calorie-restricted diet, and the bulk of randomized studies is much, much better. This is from Chris Gunner's. These are the last 23 studies. Everyone loses weight, and the low-carb diet loses significantly more weight, and people actually eat less when they're on it. So if you really want people to eat less, don't tell them to eat less. Tell them to eat less carbohydrates. And when patients from the Ebling study lost weight, everyone's resting energy expenditure basically went down, though not everyone, most people. It went down the least in the very low carbohydrate study, and the total energy expenditure was all over the map, showing how heterogeneous everyone is. It actually went up in a lot of the low carbohydrate studies. So this is why when people go on these diets, they can still exercise. And I don't have a lot of time to get into this, but when we stigmatize people, when we continually tell them to eat less and exercise more, guess what they do? They exercise less because they feel bad about themselves. So it doesn't work. It's been shown in studies not to work, and we need to stop telling people that. So my tangible recommendation number 2 to patients is eat foods that allow us to eat less, eat foods that allow us to exercise more, eat nutrient-dense and vitamin-rich foods, basically get more bang for your buck. If you're going to try to eat empty calories, you're going to end up miserable, hungry, and overeating. My last but not least recommendation is to eat foods that fuel our cellular machinery to offset free radical damage. We want to support the antioxidant defense system, but we also want to avoid excessive oxidative free radical damage. So don't eat foods that are actually going to increase free radicals. So replace with foods that fight inflammation and reactive oxygen species, and replace with foods that feed the microbiome, which helps to offset that inflammation. So the 3 other foods, besides discussions of macronutrients, I tell people to eat green leafy vegetables, broccoli, foods that have sulfur that increase NRF2, support our antioxidant system, and carcinogen detoxification. Supporting the bowel bacteria does a similar thing. So berries, high fiber fruits, and I tell them to use spices, which also increases the immune system. I'm running out of time here, so I'm going to cruise through. Finally, this means they're going to eat more fats. I tell everyone not all fats are the same. Polyunsaturated fats have more openings of carbons where they're not bound to hydrogens, where free radicals can bind. When you eat polyunsaturated fats, especially when they're heated up on your stove, you can increase the amount of free radicals that come into the body. And that's why in a randomized study, lung cancer was increased in men that were put on a healthy experimental diet of vegetable oil. And at the end of the study, they started dying more often. So I'm just going to cruise through. My last 2 seconds is, if you look at different fats, it's not the source, it's what the animal that you're eating ate. So in grass-fed beef, vitamin E, vitamin A, beta-carotene, conjugated linoleic acid, and omega-3s are all higher. These are all cancer-fighting foods that are higher in the same food based on what they eat. So final recommendations, don't eat less, eat foods that make you eat less, avoid blood glucose stimulation, stress appropriately, question, research, and ignore epidemiologic studies, or else we're going to end up with another slide like this for cancer prevention recommendations. Any questions? Sorry, I ran over.